Welcome to our clinical Q&A program. Before we bring the doctors on, I would like to take a moment to thank our individual donors and funding partners for making programs like this possible. I would also like to remind everyone that the clinicians are sharing their knowledge based on their experience, and you should not consider their response a second opinion. Now, let's welcome Dr. Foss, Dr. Girardi, and Dr. Sethi.
Thank you, Autumn.
Thanks, Adam.
All right. Dr. Girardi, welcome.
Yes, thank you.
Let's go ahead and start with our first question. What test do I need to undergo to determine if I progressed or developed another form of CTCL? Dr. Girardi, if you want to take this one.
Yeah, I think this is a great first question. CTCL is really a cancer of the skin, but also the blood and the lymph nodes. So testing around progression from where you started and changing to a different form is around reevaluation of those compartments. So for the skin, that starts with a full body skin examination with a dermatologist who specializes in cutaneous T-cell lymphoma. It may require multiple skin biopsies, even if you've had them before, because sometimes the cells change and their tropism, what part of the skin they home to, changes. It may involve blood testing again, especially flow cytometry that looks at all the different types of T-cell markers to evaluate whether there's been expansion or involvement of the blood. And then to evaluate the lymph nodes, the standard most informative test is a full body scan, a special type of CAT scan called a PET CT scan that is so sensitive in looking for any type of involvement with lymphoma inside the body, especially the lymph nodes, but also any organ. So those are the full range of tests to work up for that.
Does stem cell therapy work best for large cell transformation MF disease?
Well, stem cell therapy actually works well for many of our patients with advanced disease, be it Sezary Syndrome, patients who have advanced lymph node disease, and certainly large cell transformation falls into that category. So it's not really just one thing that makes a person eligible for transplant. It's not just the stage, it's also the clinical course and their history and how they've done with different treatments. For instance, if somebody responds very well to the first or second treatment we give them, we wouldn't really consider them for stem cell transplant. And there are certainly patients with large cell transformation that just have one area of skin that undergoes transformation. We could treat that in some cases, even with radiation, that gets better, and then we can continue to follow that patient. They don't necessarily need a transplant. So I would say, yes, large cell transformation is one of the things that we consider to be higher risk, but it's really a complex interaction between the type of disease, the treatments, and other factors with the patient as well.
Okay, thank you. Our next question, how is remission determined with the skin in MF? Will our skin ever be clear or will it turn from red to brown? How about you for this, Dr. Girardi?
Yeah, this is another great question. So on one hand, it should be obvious if you're in remission because CTCL is something that's on the outside of your skin. And so if you're clear and a doctor who does a full body skin examination can confirm that, then that could be a clinical remission of the skin. But some patients will experience a hyperpigmentation, even when lesions have resolved. So I think that the question is pointing to, we see some brown discoloration, and this can be different in different types of pigmented skin. More common, the more baseline pigment you have, the more likely you are to experience pigmentation upon a resolution of a skin lesion of CTCL. So when we look closely, both doctors and patients, at whether a lesion is persisting, it's really about the erythema, redness, the scale, flakiness, the symptoms, itch or burning, and less so about the pigmentation. So if it looks like normal skin lines and the pigmentation is kind of fading slowly over time, then probably that lesion had resolved before even the pigmentation resolves. The pigmentation could be the last thing to go away. It kind of persists for a while, and that can be disconcerting, but not necessarily a marker of involvement. Now, a doctor can also do a skin biopsy of a pigmented lesion and see if there are any persistent CTCL cells within that area of pigmentation to do a histologic confirmation. But really, if everything's progressing nicely, I always tell patients, if we see nice flat brown spots and no longer see thickened red spots, then we're in a good place.
Okay, thank you for that. On our next question, I have recently advanced to B1. What are the available types of treatment and long-term prognosis? Dr. Sethi, do you want to take that one?
Sure. Yeah. So that's again a very good question. So B1 means that there is some amount of blood involvement. Again, it could mean that the patient is developing Sezary syndrome. It's based on the number of cells that are seen in the blood. So there are certain agents that work particularly well when there is disease in the blood compartment. One of them is Mogamulizumab, which is an antibody drug against a surface protein called CCR4, and then we also have other agents like brentuximab and also gemcitabine, some of the other drugs that work. Also, we know that ECP works very well in the blood compartment. In terms of prognosis, again, the level of blood involvement really is shown to drive the prognosis. Like we know patients who have B2 disease, which is more than 1,000 Sezary cells, they really do have much worse prognosis and a shortened overall survival as compared to those that have B1.
Thank you for that information. Is the incidence of cutaneous lymphoma increasing, or is early diagnosis just getting better? Dr. Girardi?
It's always hard to separate this. This is a question that's come up with in multiple settings, including cutaneous T-cell lymphoma and, for example, melanoma. Of course, our big goal is to have patients become more aware and for doctors to have be fully educated about the possibility of cutaneous T-cell lymphoma. I think that for early disease, I still see so many misdiagnoses, delayed diagnoses, and then advanced disease. It might be a little more obvious that something's wrong, but having the expertise on correct subtype and appropriate workup comes into play. The short answer to the question is I don't have a clarity on incidence versus on early detection. That would be a bias on that. I would say I've been at Yale for over 25 years, and I've seen more and more cases over those years, and so it does give me pause to worry a little bit more about the incidence, but I don't have a solid answer for you on that.
Thank you. It's a good reminder that we don't always have answers to the questions when it comes to this disease. Our next question is, can you please speak more about clinical trials with ECP? Dr. Sethi, how about this one?
Sure. So, ECP treatment is available as a standard of care, especially, in more advanced disease, including Sezary syndrome. However, there are a few trials that are looking at combinations. For example, with Mogamulizumab, again, that's a drug that has particularly good efficacy in Sezary syndrome. And then there are some other studies that are basically evaluating ECP in a more structured way to look for, a particular to gather more particular outcome data, but it's still being used like as a standalone therapy.
Thank you for that information. Our next one, I have advanced stage CD4 plus folliculotropic LCT CD30 plus and have had multiple systemic and topical treatments. I'm now receiving brentuximab vedotin on my second infusion, and it appears effective so far. Is this treatment something that can be tapered to a maintenance dose, or is it just continued until progression or your body can't handle? And I want to do the reminder that the doctors are going to answer this based on their experience, their patients. They have not seen your records, so this is going to be based on their knowledge. Dr. Foss, this seems like a perfect one for you.
Great, thank you. It's a very good question, and patients oftentimes ask us this question when they're on an effective therapy, be it brentuximab or Targetin, for instance, or any other therapies, and they've had a good response. They ask us, well, how long do I need to be on this treatment? Can I stop it at some point? And one of the problems is that when we have done our clinical trials, we haven't actually really addressed the issue of when to stop. Most of our trials have shown that these agents are effective. Patients continue to get the therapy, but we don't really have good data about what happens when you stop it. I think in the case of brentuximab vedotin, you can get some very, very good responses and complete disappearance of disease. There also is neurotoxicity in terms of numbness and tingling in the fingers and the toes as you continue on with this drug, and that is something that you have to watch out for. So I think it's very hard to think about using this drug for the long term, unlike, say, Targetin, which is an oral drug, and our patients take it for years and years. So generally speaking, in my practice, what I try to do is wean people off the drug. So I would go to every 4 weeks, and then after a period of time, I would consider stopping the drug. But again, there's really not a lot of data in this regard. And I would say that it really depends on the individual patient and the treating physician, side effects that might be occurring, and making that decision, I think, in collaboration with the patient is really important.
Right, thank you. And as you were answering that question, someone added in a live question specifically about it, but they actually are having some neuropathy. So I wanted to pop the question back up in here real quick to see if you had anything you want to add. It sounds like you may have already addressed it, but if you had anything to add, I wanted to put this question up real quick.
Yes, thank you, Autumn, and I'm glad that this question came up because we actually have learned a little bit about the resolution of the neuropathy with brentuximab. And that was in the setting not of CTCL, but of PTCL, when we did a big randomized clinical trial treating patients with chemotherapy, CHOP type therapy with brentuximab. So we treated them up front for aggressive T-cell lymphoma. A lot of those patients were cured. And recently now there's 5-year data that's actually looked at the peripheral neuropathy and the resolution of the neuropathy. And what they basically showed is that about 80% of patients actually did have improvement. In many cases, they had resolution. So I think that's a piece of good news. But again, that's, one group of patients, one study. But I think it at least indicates that we can see improvement over time. I want to point out again, this is another one of those factors that's patient specific. Some people get much more neuropathy than others, and we don't really understand why. So again, I would say that you can extrapolate from what I'm saying that there's a hope that it would get better, but that may not be true for everybody.
Thank you so much for that additional information. How does one distinguish between plaques and hives? Dr. Girardi?
We have a whole separate language in dermatology between flat patches, raised plaques, papules, individual bumps. Hives are really not something that's on top of the skin. It's kind of in the deeper layer of the dermis. It's associated with edema, kind of like a fluid that's in the skin itself. By definition, hives move within hours. So hives are kind of an allergic type of reaction in the skin that'll come and move. CTCL are really fixed patches or plaques on the skin. There's a bunch of things to distinguish that from, most notably eczematous patches or eczema, psoriatic patches or psoriasis. Those are the most common distinguishing what we call parts of the differential diagnosis, things to separate it from and be clear about. And those are common inflammatory skin conditions. So, and look more similar to CTCL than, for example, hives might.
Thank you. Next question is there a timeline for mining the data for allogeneic stem cell transplants? Looks like another one for you, Dr. Foss.
Thank you. And I think this gets back to my talk when I mentioned the fact that we did the meta-analysis and we looked across a number of different clinical trials and we collated all that data to try to better understand which patients with CTCL, number one, are getting a transplant, and then which patients are benefiting the most. So we actually have collected that data. We've created a big database. And now we're going the next step, which is trying to go back and look in more detail at those patients in terms of the depth of their clinical response, what treatments they had before transplant, trying to answer some of those fundamental questions that we asked. So that is ongoing. We're publishing our first paper. It's coming out in the Bone Marrow Transplant Journal. We also have a second paper coming out probably in the next year. And I'm hoping that this is just the beginning, that we've collected a group of investigators and transplanters and CTCL treating physicians from around the country that are now interested in this question. And there's ongoing collaboration to address this in more detail. So hopefully we'll see at least another paper coming out over the next year.
Right. Thank you for all that additional information. So our next question, I think it's got something for all of you. So maybe we'll have everyone weigh in on this one. For Sezary Syndrome, erythroderma, and blood involvement, with so many treatment options, how does a doctor determine whether to treat a patient with a single treatment option or a combination of treatments? Dr. Girardi, you want to start us off?
Yeah, this is a great question. I think that as we've evolved and learned as physicians how to combine therapies, we've become quite good at it, where we can take different therapies with non-overlapping toxicities. That means they work well together without increasing side effect profiles. And then years and years of real-world use, including formal clinical trials, but also what we say as empirically understanding and acquiring experience in the field. So with ECP or photopheresis, we often combine that with other modalities. One of them would be oral targretin, the pill, a retinoid, and it works quite well. And patients tend to do well when they're on both. Sometimes we also add an immunostimulating agent like interferon injections. There's both an alpha type and a gamma type, and we've used both. And sometimes we use all three, something we call triple therapy that seems to really synergize when they work together. And then there's kind of sequential therapy. So we might start a patient on photopheresis, keep a patient fairly well controlled for even a number of years, and then the disease may advance. And then we work with our colleagues in oncology, including especially Dr. Foss and Dr. Sethi here, and they may get a modality such as mogamulizumab that might knock down the counts in the blood, and the patient again becomes eligible for a more gentle treatment such as photopheresis and oral targretin. So, we work starting patients on combination, but also we do it sequentially fairly often.
I just
Dr.
wanted,
Sethi,
I just wanted to say one thing, and that is that we work very well as a team. And generally speaking, Mike, who runs the Photopheresis Center, sees these patients first, and many of them are candidates for this kind of immunotherapy, not exposing them to chemotherapy, if they can respond very well to biological modalities. But sometimes a patient comes in, Tarsheen and I both see these patients that come in with very, very aggressive disease, perhaps with very bulky lymph nodes that we biopsy that show transformed or very aggressive disease, or they come in with Sezary syndrome and lots of cutaneous tumors, very bulky disease. They're very sick. And those patients sometimes have to move directly into chemotherapy. Tarsheen has done a lot of work with some of the single agents like brentuximab, mogamulizumab, and perhaps she can speak a little bit about that. I see these patients when they're more advanced and we start thinking about transplant. We start at least talking about transplant. even if they're perhaps going to go on one of Tarsheen's single agent modalities, we still at least have that discussion in case that comes up in the future, and it does for many of these people. So Tarsheen, you've had a lot of experience with single agent therapies for these patients. What are your thoughts?
Yeah, absolutely. I do think that we always get started with single agent, and especially in patients who do not have rapidly progressive disease. Again, oftentimes for Sezary syndrome, mogamulizumab is our first choice. Pralatrexate is another drug that is effective, for this particular this particular compartment of disease, this particular presentation of CTCL. But like Dr. Foss alluded, for more rapidly aggressive disease, especially patients that we want to get a deeper response for transplant, we sometimes move on to more intensive chemotherapy-based combination options.
Thank you all for that information. What treatments have proven most effective for skin itching? Dr. Girardi?
Yeah, as the dermatologist in the room, I guess I'm getting this question. And this can be a real challenge. Some patients, a lot of patients with CTCL have incredible amounts of itch. The medical term for that is pruritus, and it can be very challenging to control. First, we try to control the disease. So treat the disease appropriately using single or combination therapies. But there are some kind of tricks that we've learned over the years about which particular treatments may be more likely to help. One of them is phototherapy. Narrowband ultraviolet B therapy is quite effective at helping to control itch in CTCL patients across many types, but especially patch plaque early stage 1A and 1B. The other thing is topical corticosteroids. So that's the one that comes in a large tub is triamcinolone, but there are many different types of corticosteroids of varying strengths and varying vehicles, meaning gels, ointments, and creams. And to match that and help coordinate that with a patient's preference can be very helpful. There are some topical over-the-counter anti-itch creams that are available that some patients find incredibly effective. One made by Eucerin, one made by CeraVe, and one called Sarna. And these can be quite cooling and helpful for patients and give them relief and not have concerns about how many times they apply it. There's an old tried and true regimen we do called open wet dressings. This is real simple, completely safe, and anyone can do it at home. And that's getting undressed, taking a bath sheet, wetting it with lukewarm water, and putting it in single layer contact with the skin, and just letting it stay in contact for about 10 minutes. And what this does is it drives a little evaporation, and evaporation is very much a cooling process on the skin. So it constricts the blood vessels and really can give tremendous relief of itch in a very safe emergency way for any patient to be able to do. And right after that, applying some of the anti-itch or cortisone cream like triamcinolone can be a 1-2 punch to really help decrease that itch too. There are also some pills that can be quite helpful, but really I like the skin-directed modalities the best.
Thank you for all of that. Itch is always something that needs to be controlled. Our next question, are there any significant difference between the various places that offer bone marrow transplant for advanced aggressive MF? Dr. Foss, would you like to take this one?
Sure. Another really great question. The important thing with MF patients going into transplant, I think, is having a multimodality team, because part of the transplant involves doing skin radiation, as I mentioned in my talk. But also a big part of the whole process involves collaboration with our dermatology colleagues that are experts in dealing with CTCL, because oftentimes patients may still have skin lesions going into the transplant. And then certainly after the transplant, there are other issues that can occur, such as cutaneous graft versus host disease. But I think it's really important for patients to be able to access this multimodality approach. So there are now a number of centers around the country, and I think many of you patients probably are being treated at these centers, where they have dermatology colleagues, transplant colleagues, and oncologists all working together. I know some of you probably live in rural areas where you may not be able to access that, and you may end up getting a transplant at a center that doesn't really have multimodality approach. But the other physicians in the community and those of us on this call and our colleagues are willing to collaborate with physicians who don't have access to multimodality approach. And we're willing to work with the transplant physicians in order to optimize the outcome for patients. So I don't think patients should not consider a transplant just because they don't live near one of these centers. I think what needs to be done for those patients is work on a collaborative model, and we can get those patients the kind of care and expertise that they need.
Thank you. Next question, can a woman with diagnosis of MF still receive hormonal replacement therapy to manage symptoms of menopause? Dr. Sethi, would you like to try to answer this one?
Sure. So that is a tough question because, again, this is, hormonal therapy has, come a long way. And we do know that there is an increase, depending upon, what the hormonal, components of the hormonal therapy is. In patients with any type of cancer, there is an increased risk of blood clots. So it really needs to be a discussion between the CTCL treating physician and the gynecologist and the patient to make sure that the combinations that are used or offered are the ones that have lower risk of the lower risk of blood clots.
Okay, thank you. So I'm looking for natural treatments I can do myself. What do I need to stay away from? Foods, chemicals that are good or bad? Does stress have an effect? Dr. Girardi, you want to give some insight on this one?
Yeah, I think that, a lot of patients and a lot of doctors want to do, whatever they can from a nutritional standpoint, from a supplement standpoint to make sure a patient's healthy. I tell my patients, the most important factors to help them deal with their disease and do what they can naturally are the same things that they would do if they didn't have the disease. And that is about diet, exercise, stress management. To me, it's about the fundamentals of a healthy diet, of Mediterranean diet, of decreasing saturated fats, which can interfere with certain treatments that we give, for example, targretin, oral targretin. And so I think that there's another side of it, and that is that there's got to be real communication between a patient and prescribing doctors about what natural supplements they may be using, because some of them will interfere with some of our treatments. For example, you should be not taking high doses of vitamin A if you're taking oral targretin. And then also some of them can cause interference with liver enzymes and other tests that we order to check on the health status of the patient. So I really would not advocate for any high doses of supplements while undergoing a therapeutic regimen for CTCL, but a low dose multivitamin, healthy diet, exercise, and stress management would be my fundamental recommendations.
All right, thank you. Our next question, for patients who have maintained early stage disease for long periods of time, have you found any connections between treatment strategies or lifestyle factors that you would advise us to follow? So it kind of ties into the last one, Dr. Girardi, if you want to take a first stab at this.
Sure. I think, stage 1A, less than 10% of the surface area involvement with patches. Stage 1B could be over 10%, but we've had patients who can maintain remissions or close to remissions for decades with those stages. They tend to have positive attitudes, tend to be plugged into the healthcare system, work with the doctor very closely, communicate effectively, and follow regimens and be willing to change regimens as we move on. They tend to be healthy in other ways, so making sure that they are doing what their primary care physicians may recommend in terms of controlling other health concerns, from diabetes to hypertension to hyperlipidemia and hypercholesterolemia. They tend to exercise. They tend to stay motivated and keep on going. They also tend to come to meetings like this. That's about being educated as a patient. It's about sharing experiences sometimes with other patients. And I think that these are personal connections that are also very important to the longevity of a response.
All right, thank you so much. Next question, are stem cell transplants generally these days being more sourced from blood rather than bone marrow, or just for CTCL patients? Dr. Foss?
Another very good question. So I mentioned that most of the transplants for CTCL were done with stem cells, and that is true across the board. And it's primarily because stem cell is a very easy source of getting the cells from peripheral blood. Doesn't involve doing a lot of bone marrow biopsies to suck it out of the bone marrow. And we know from years and years and years of experience that peripheral blood stem cells work just as well. I also just wanted to make sure that I think I mentioned it in my talk, but you can go to the CIBMTR website, and that's a tremendous source of information about all types of transplants that are done in the United States. And you can see the actual numbers of patients that get peripheral blood versus bone marrow, and you can see the different diseases that are treated as well. But I think if you go to that website and you look, you'll see that about 80% of transplants are now peripheral blood.
Thank you. Looking for stage 1 care and support details. What kind of specialists do we need to care for MF? Dr. Sethi? Yes,
that's a very, very important question, especially for mycosis fungoides. It's such a complex disease, and part of it is because it can be a diagnostic dilemma. As Dr. Girardi had mentioned earlier, there are a number of differential diagnoses that need to be considered. So we want to make the right diagnosis so that patients can be treated in the right manner. As we know, mycosis fungoides can really affect a patient's quality of life. So that part is very, very important. So what I believe is that this is one of those diseases where you really want to directly or indirectly have access to a center that has a good pathologist that has expertise in this field. Dermatologists like Dr. Girardi, and hematologist oncologist, as well as in patients with more advanced disease, transplant physicians. But for stage 1 disease, I would say again, oftentimes the dermatologist will take the lead on that. But in centers like Yale, we work as a team, and we always different a radiation oncologist sometimes might be involved depending upon what we are seeing, and so really these are very important to have a team that can take care of you right from the beginning, no matter what stage of disease it is.
Thank you for that. Next question, in your experience, is extracorporeal photopheresis effective for stage 2B? Dr. Girardi?
Yeah, I think that extracorporeal photopheresis is really it's a treatment of the blood. Its biggest experience is with patients with blood involvement, regardless of what else might be on their skin. But for patients who have tumors on their skin, photopheresis alone will not clear those patients. So that would only be appropriate in the setting of combination therapy. We often will work with our therapeutic radiologists, including Dr. Lynn Wilson and others at Yale, who will effectively flatten those tumors, and really with total skin electron beam can clear the skin certainly very effectively in a matter of months. And we'll do that in combination with photopheresis. And while there's not a ton of data on clinical trials in that regard, there has been some over the years that has shown that there's good synergy by combining them and improving survival in this way. And if you think about what's happening, it makes a lot of sense. When the skin is irradiated and tumors and plaques are treated in this way, a lot of the cancer cells will be released into the bloodstream. And then photopheresis can serve as a way to stimulate an immune response against those components, first of the dying cells, but then also potentially transferring that immunologic efficacy to the live cells. And so, while there's not a ton of randomized controlled trials, which are really the standards by which to make judgments and answer these types of questions, I think there is good world experience on combining photopheresis in many settings, including those in which we irradiate tumors.
Thank you very much. Our next question. I have B2 Sezary and I'm being treated with bexarotene, interferon, and phototherapy. I hear about ECP and Mogamulizumab and wonder if I'm getting the best standard of care available. How do I know? Also, I've been told bexarotene may take up to 9 months to work. Is this the case in your experience? So, Dr. Girardi, you just talked about ECP. I don't know if you want to add anything additional to this question, and if the rest of you want to weigh in on the rest of it.
Yeah, I'll jump first and say, with B2, more blood involvement in your disease, I think that you were appropriately treated with combination therapy, including photopheresis. And like I said, we do often combine that with oral bexarotene, targetin, and interferon injections. And we will also use phototherapy as well to help get those lesions in the skin. So again, getting the disease from the inside outside. So that seemed very appropriate. Combining mogamulizumab with photopheresis, I think the data is coming in that they're very compatible and may offer, again, a way to combine treatments to treat more aggressive disease, especially with blood involvement. Oral targetin can take 3 months to work, 6 months to work, 9 months to work, 12 months to work. It really is patient to patient, how high we can get the dose up safely and what other combinations are being used. In general, as long as we're keeping disease under fairly good control, it's not progressing. That's goal 1. Goal 2, we see decrease in disease, skin improving, blood counts going down, and then we feel better again. And then reaching for that 3rd level resolution. So we don't always get to resolution. Sometimes we're satisfied with getting disease to be maintained at a certain level where a patient can live life and do all of the things, or at least most of the things they want to do in life. And if we can prevent progression for a long period of time, then that's also a way we can feel at least partially successful in keeping this disease under control.
I think another important point, getting to what Mike just said, is that there are different compartments of disease. So there's the blood compartment, the skin compartment, and also the lymph node compartment. So when you think about yourself as being, say, a B2 patient, you have to think about the whole picture. So what seems to be an appropriate treatment for one B2 patient may or may not be appropriate for another one. And as we move forward with the treatment, we look for response in all of those different compartments. So I think it's really hard to extrapolate from one person to another without looking at the whole picture. And I think these are very good questions, and that brings up the whole point that you should be talking with your physician about these questions, and don't hesitate to bring this up, to get into a discussion and ask, well, why this and not that? Because I think, anybody treating this disease, any of our colleagues that you might be seeing would be really happy to help you to answer those questions.
For sure, thank you. On our next question, I underwent 16 rounds of brentuximab vedotin from 2021 to 2022, but is now back with full body plaques and red hive-like rash spots. What treatment may be most effective at this point in my battle? I had 6 rounds of brentuximab 2 in 2008 and did TSEBT in 2019. Dr. Foss, would you like to take this one?
Oh, okay. So this is, can you put the question back up? Okay, so basically, this is a patient who had brentuximab, has, it sounds like plaques, but not tumors. And then had radiation, I think, most recently. So I guess I would ask the question of where you're at with your disease right now. It all depends on, again, the different compartments, as I just talked about. So what the characteristics of the disease are in your skin. Is it just plaque disease? Is it tumors? Is there transformation? What's the extent of disease in the blood? Is there lymph node involvement? So I think in terms of thinking about how we make that next treatment decision, we take into consideration all of these different factors, in addition to the treatment that you already had. So one thing I'll say is that it is possible to go back to treatments that you already had if you responded well to them. Say, for instance, like now you're CD30 positive again, you could consider brentuximab. In addition, there are clinical trials, and a patient like this might consider, if there's a clinical trial available with a new agent, this might be an appropriate thing to do. Also, not combination chemotherapy, but some of the single agents that we use. We're now actually looking at combinations of some of the biologic agents with some chemotherapy. For instance, Dr. Sethi has a study where she's combining brentuximab with pembrolizumab. So even if you didn't have an optimal response to brentuximab, perhaps this is a good combination. So again, I think at this point in time for this patient, what we really need to do is sit down and look at the different compartments of your disease, how extensive the disease is and what it is right now, and then what our treatment goals are, what are our options and what are our goals. So if a patient like this is refractory, say, to multiple therapies and has more aggressive disease and tumors and other lymph node disease, this is a patient that may want to see a transplant doctor, for instance, and then think about whether we might be heading for a transplant, maybe not now, but that might be in the future. So again, I think multifactorial situation here that requires, again, the input of colleagues in oncology, colleagues in dermatology, and then perhaps a transplant colleague as well.
Thank you for that it was complex but thorough answer to that question. Will phototherapy also be something we need as a forever treatment like Targretin, or is that something we can wean off of? Don't know who'd like to take a phototherapy question.
I'd probably prescribe more phototherapy for this condition than my oncologist. So it's very patient dependent and experience dependent, meaning a patient can undergo a course of phototherapy and clear nicely in a matter of 3 to 6 months with 2 and sometimes 3 treatments a week, but I usually go with 2. I feel we can get there with 2. It may take a little longer. The doses are, slowly increase, so it can take time, and we want to do it safely. Patients who achieve remission with phototherapy, different centers will treat that patient differently. Some centers will have a philosophy that they want to keep the CTCL away and will do maintenance phototherapy. And I'm one of those physicians and at one of those centers where we have a long experience from Erwin Braveman to Richard Edelson, who have treated and started treating patients with phototherapy long before it was really understood as a therapy for CTCL. And so the way I do this is once a patient clears, we start to take a tapering approach. So we go to once a week, once every 2 weeks, once every 3 weeks, once every 4 weeks. And then I'll have some patients who go to phototherapy once a month, and they get summers off, and they'll stay clear indefinitely. Now, when's a good time to say, okay, let's throw caution to the wind and just stop? That's very much, again, a personal decision with the patient. For some patients, they'd much rather not want to have a surprise of seeing their lesions come back and then have to start from square one twice a week. and that's just, seems like very daunting for them. So they'll want to stay on maintenance. Other patients will be tired of even going to a phototherapy treatment center after years. But some of them do home therapy, and we help patients obtain boxes in their homes that insurance companies pay for. And so that can be very convenient and a way to really maintain and keep patients clear. So it does vary, but maintenance is my general rule.
Okay, thank you. And our next question, for Sezary syndrome, is mogamulizumab best by itself as an individual treatment, or is it better as a combination treatment concurrently with, say, ECP? Dr. Sethi, would you like to answer that one?
Sure. So, the way that mogamulizumab was studied and the way that we have the most data for is to use it as a single agent. But again, as Dr. Girardi mentioned, and as I mentioned, some of the other centers are looking at the combination of ECP and mogamulizumab. And really what we are trying to see is that can we maintain a response that we achieve, for example, with mogamulizumab by using going back to ECP, for example. So that I do think that currently standard of care is to use it by itself, use the mogamulizumab by itself. But I think we are really moving to see how we can extend the responses by using a combined modality.
All right, thank you. So I want to make note that we are a little under 15 minutes. So we might maybe kind of go into what we would call our lightning round. And the next couple questions are on phototherapy. So these next two ones will be for you, Dr. Girardi. I'm getting phototherapy. When can I use non-steroidal anti-inflammatory drugs?
Yeah, there's always concern when a patient's receiving phototherapy that medications that they take may make them more photosensitive and can result in a phototoxic or burn reaction in phototherapy. NSAIDs is on that list, and it's possible that will increase the sensitivity. In general, you take it after your treatment. It'll help calm some of the potential side effects, and it won't make you photosensitive. It's not a very photosensitizing category of drugs. In general, it does vary patient to patient, but my recommendation is don't take such medications right before. The bigger concern is really along the lines of antibiotics. Some of those are very photosensitizing, in particular the cyclins like doxycycline. That should never be taken prior to any phototherapy exposure. Even low doses for acne can be very sensitizing, for example. But most of the time, we'll see doxycycline prescribed for a staph infection, and a patient should make the treatment centers fully aware of any medications they're on, any new medications they might be taking before they get in a light box.
Okay, thank you. Our next phototherapy is, I'm a male doing phototherapy with athletic support. I have some itching and redness in my groin area. Is it safe to do phototherapy without anything on to treat my groin area?
Great question. So treatment centers will vary their recommendations on what to protect. In general, CTCL, mycosis fungoides, likes to appear in photoprotected areas. So, a jock strap can be a plus because it's minimally protecting an area that can be very sensitive, but it can also have drawbacks in that if CTCL involves the scrotal or penile area, that it's not going to get treated with the light. So that needs to be really discussed with your physician, in particular dermatologist who might be examining you very closely in that area, and make a decision. Sometimes we do a very short part of phototherapy exposure without any protection there, to really allow the treatment to occur in an area that you might be protecting otherwise. But you can't just take it off when you've already had your dose ramped up, because that can result in a very severe burn. So communication and clarification around that. There are other things that make the groin itch too, so you need to be checked out for fungal infections, intertrigo, and these kind of things that can be treated with creams, and maybe that was the problem with the itch. The other thing with athletic supporters or jock straps is the straps. They can be very disconcerting in someone receiving phototherapy because they don't always necessarily line up in the same place. So when it slides slightly up or down, you can get a burn in some of those areas. So be very careful with that. Some of my patients have been very creative in using a handkerchief and a very loose Band-Aid for male genitalia protection. So, or a sock that fits just right. So there are people who can be creative in that way. It could be discussed at each treatment center. I work with a lot of treatment centers. We have one of the largest ones at Yale, and we make our recommendations, but it does vary treatment center to treatment center. Just because I do think it's really worth mentioning, one of the biggest mistakes I see is patients not taking their underwear off. Because again, buttocks, thighs, suprapubic area, very, very common areas for mycosis fungoides. But, there's kind of this natural reaction of people to keep their underwear on. But for the most part, we're treating your entire skin with phototherapy, save for a little bit of photoprotection in some sensitive areas.
Great, thank you very much for that answer. Can mycosis fungoides become Sezary syndrome if it progresses, and what distinguishes the two? Dr. Sethi, you want to take this one again? This one?
All right. So yes, there are patients who do present with advanced disease, early on when they're diagnosed, but there are others who have had like more early stage disease and then progress to more advanced stage disease. Sezary syndrome is defined by the presence of erythroderma, where more than 80% of the skin is involved by a red scaly rash. Along with that, there is blood involvement with Sezary cells, and then there could also be some lymph node involvement. That's what we call the triad, or the three things that we see with Sezary syndrome more commonly. So definitely that can happen. In the way to more than distinction, I think the more way to see to assess for Sezary syndrome is beyond the skin exam, is to check for blood involvement by flow cytometry, and also looking at some genetic studies in the blood.
Great, thank you very much. What is the most important thing to review for a Sezary syndrome patient when looking at our flow cytometry report? Should I be looking for anything specific, CD positive or CD negative markers? So who would like to take this one?
I can start with that one. So because of ability for patients to now see their charts and see all these details, what many patients will see are all the different CD markers that get done for the flow cytometry. The flow cytometry involves basically staining the lymphocytes with different markers for like CD2, CD4, CD26, et cetera. And then looking at the percentage of cells that express those markers. And sometimes they're looking for 2 markers at the same time or 3 markers at the same time. So what you'll see is all these different numbers, lists of numbers. In many centers, they don't actually give you the interpretation either. So in our center, we get the report with all the numbers, but then also we get an interpretation that says something like 26% of the circulating lymphocytes are Sezary cells. So that kind of gives us a number to hang our hat on. There are specific markers that Sezary cells have, typically CD4 positive and CD7 negative, but sometimes that's not always the case. Sometimes they're identified based on other markers. So it's a little bit tricky if a patient is actually trying to look at this data and figure it out. I mean, Mike does a lot of work in his lab with Sezary cells and looking at markers. I don't know if you had any advice for patients, Mike?
Yeah. First of all, it's a challenge to interpret a lot of these numbers for a patient, and I think so. Trust your doctor to interpret them. But if you want to really zoom in on a couple of numbers, I think one is the CD4 positive, 26 negative CD4 positive, CD26 negative is one of the most reliable markers for abnormal cells in a patient along the lines of a CTCL phenotype. You have to understand that you can have 10%, 12% of your T cells that normally have that CD4 positivity, 26 negativity. So that's why really understanding on how to look at that. That's one number that, along with loss of 7, can be very helpful. The CD4-CD8 ratio can be very helpful. A normal patient is around 3, 3.5. A CTCL patient with blood involvement might be upwards of over 5, over 10. And so seeing that gives you information about involvement with abnormal CD4 cells, but also how well your immune system is doing otherwise. That is the CD8 compartment. The CD8 compartment is typically not a phenotype we see in patients with mycosis fungoides or Sezary syndrome. So that ratio where we have a CD4 over the CD8 can be very informative in 2 directions. So I find that to be particularly helpful, and I pointed that out to patients. That's something they can look at and follow over time to see how healthy they are in terms of the CTCL and their immune system. We do some other second-level analyses at Yale. We do a V-beta analysis, which can look at expanded populations within a profile of T-cell receptors on CTCL cells. We can also do cytogenetics. I've worked with genetics to institute a cytogenetics panel that is more specific for CTCL, as is the case with other leukemias and lymphomas. So we have that available to us at Yale as well to help really understand the degree of involvement, but also some of the genetic mutations that are present.
Okay, thank you. We have time for one more question. I was told in 2021 that Merck Interferon ALFA-2B was being discounted, I believe they mean discontinued globally, and my very effective treatment abruptly stopped. I am hearing about interferon tonight. What forms of interferon are currently available?
That would be Mike.
Yeah, great question. Interferon is available in forms right now. Interferon alpha is available and interferon gamma are available. Brand names Pegasus on one, and help me out, Francine. Intron,
right.
Yeah, on the other. So, yeah, I think sometimes this takes a little work by the prescribing physician. They're slightly different mechanisms of action, these interferons, but they still seem to work quite well, both types in CTCL, and work quite well also in combination. So, yeah, especially if you responded to an interferon before, you're very likely to respond again. So I would pursue that.
Okay, thank you so much for that. And I want to say thank you again to all 3 of you for taking the time out of your busy schedule to do your presentations today and to answer all of the questions that you answered so wonderfully for everybody. And if you could stick around for just 1 minute after the show, I'd appreciate it. And I want to say thank you to all of the patients and care partners that joined us. And I hope you found some very good information. And as a reminder, all of the presentations, including this Q&A, will be out on the Foundation's YouTube channel shortly. And then I do ask as you close out, would you please complete the survey link that will pop up, because it really helps us know what it is that we're doing well and what we could do better. Thank you all and have a good rest of your night.